Obviously, this seminar is being recorded for everyone to be aware of. And my name is Francesco Paolucci. I'm professor here at the University of Newcastle, and I'm chairing this PhD talk, which is an opportunity for PhD candidates to share with us their ideas, work, progress, papers, and start, bringing all their peers, but also in some cases, really the relevance of the question is so topical that it's clearly important also to involve the broader community. Tonight we have this morning. I mean, some of you are. I see that they are all connected from overseas. So welcome everybody. We have Andrew Matthews, who is working on his thesis. I mean, the title of the talk is about healthcare financing in Australia. It's related to efficiency and affordability, obviously. We'll understand better the focus of his work as he presents today. I think this is a very important topic. Andrew's been working with Finity as an actuary and a real leader in health policy development since he joined Finity a few years ago. Before that, he was at Medibank Australia Private Limited, which is probably the one of the most symbolic, I would say, private health insurance, because it inherited the name of a reform that was the precursor of Medicare, if you like, and it has become private really only a few years ago. Before was kind of always referred to as a real public, so almost I would say public insurance operating in the private insurance market, which is one of the characteristics and interesting aspects of the heterogeneity and mix between subsidies and private elements within the private insurance in Australia, but also other countries. So he spent some time there at Medibank as chief actuary, and he's also at Monash lecturing, and obviously has many interests, and we've been working and knowing each other for a number of years. So it's a pleasure to have him here. So I will say a few words about why this talk today is very important, and not only here. Clearly, we are facing quite significant challenges globally. Most countries are really facing similar situations from a macroeconomic perspective. So increased debt, rampant inflation, a shift really in the approach, I would say, of central banks to try and combat this inflation. Many think that because the supply side, we're not dealing with these problems with the right instruments. Mainly, it's moving away from quantitative easing towards more restricted approaches, meaning that increasing the interest rates are becoming almost the expectations these days, which puts a lot of pressure on the economy. Australia is kind of special in this because, in fact, of its nature in terms of the core of its economy, and in fact, one of the aspects that really has benefited Australia in some sense, that has benefited from the inflationary pressure. It's also the increase in the price of minerals. So of course, the judge is still out. There is a lot of panic, uncertainty in financial markets, which again put pressure on states in terms of their forecasts in terms of that sustainability and their ability of course, being sort of effective in managing that increase during the COVID crisis in particular. So there are a lot of challenges for governments. Nevertheless, many states in Australia, and I would say in general, the health budget, if I think of New South Wales, has actually increased for actually in an unprecedented way, 10% increase, which is something that the Europeans or the North Americans would dream on at this stage, where in fact austerity measures are being discussed after the expansionist approach during COVID. So we are in a special place. Nevertheless, I would say that the discussions that have arisen and then really have started emerging during COVID between the different levels of governance and government when it comes to healthcare seem to have come to a new dawn. In fact, both New South Wales and Victoria governments are really seemingly pushing for some shifts in reforms. Now, the interesting aspects of that is that clearly we don't know what the future holds, but it seems that all these discussions about sort of the future of healthcare is really around the organization of healthcare financing. It might be that, or it clearly seems to be more likely that states want to have more states on and responsibility in that respect. And clearly there is an open question about the role and the mix between the public and private sectors. So I think this is very timely because these are issues that are debated at all levels, not only here. Andrew, after this semi-long introduction, I wanted to really put emphasis on what you're doing, which is very brave, but also, of course, challenging as well. There are many variables. I think everybody knows what the challenges are, but not really how we're going to deal with them. So that's where I really wanted to go to introduce you and your presentation today. So thanks for your contribution. And in terms of housekeeping, please, if you have questions, I'll try to manage the best I can. Just put them in the chat in the Q&A. I'll try to intersect or intervene when Andrew talk if the questions are of imminent need, but we'll try to keep it interactive if we can. So Andy, take it away. Thank you.
Yeah, cool. Okay, thanks, Francesco. And people who are listening can ask questions, right? Francesco, you don't just have to put them in the chat.
Fantastic.
Yeah. So if people want to ask a question, I'll pause every now and then so we can spend some time on that. So let's get right to it. I want to talk to a couple of slides, and just as an introduction, really want to talk about healthcare financing or funding and money, really, because I'm not qualified to talk about the care or the type of care people are getting, but I think the money affects aged care, healthcare, anything. If you're not getting the money, if there's not the funding, if there's not the financing, you're going to have problems. So I want to talk about some of those, and a lot of the literature talks about efficiency and affordability. So I'm going to talk a little bit about those and indulge in a little bit of my academic focus to sort of some of the papers I've read on that. And I'll focus a little bit on private health insurance, or PHI. So what I was going to do is explore, and you already touched on it, Francesco, that I think pretty much everyone knows what needs to happen in healthcare or anything else. There's a lot of papers on that. I'll talk some about them. There's even a paper on, well, I thought there were 10 preconditions, but I've now learned there are 13. So we'll go through some of those, right? But if it's establish what needs to happen. The thing I find most challenging is how to make it happen. So maybe some of the conversation tonight will sort of add something to that, because I don't know the solution to that. I'll talk a bit about the context. We'll talk about Australian health system, but I'm assuming a lot of people here know that. But if you want to ask a question on it, either you can ask and either I'll answer it or tap into someone in the group that can answer it. I also thought it's interesting to talk about what if there was no private health insurance, which for many of my clients would be quite a confronting question, but I think it's an important one to look at, because private health insurance shouldn't just exist because our purpose is private health insurance. It should exist because it's better than the alternative. So I thought of the question, well, what if there was no private health insurance? What does private health insurance need to do to be better than that? And then we'll touch a little bit in the end on what's the future, what are the challenges. And, the main challenges, I think, or the main challenge I've got is I think I pretty much know the what from reading a lot of the papers, or at least there's a lot of opinions out there on the what. That's pretty well researched. We'll touch on some of that. But it's the how to act. And every country is different. If I go to the Netherlands, they've been running a prospective risk equalisation system, or a health system over there for near on 20 years and improving it as they go. Australia might like to learn from some of that, but we've not got that 20 years of development. So you can't transport what they're doing here. So how to act and how to go forward is a challenge. And if we're successful, it would be the health system and private health insurance is adapting to high performing. I think there's enough papers around that say it's not high performing or optimal performing at the moment. And we're getting the best health outcomes at an efficient and affordable cost for individuals and the community now. I've lost my list of who the guests attending are, but I know, Brian, you were there, so you might want to comment on that. Actually, just go back to the what and the how, because I was exploring that to start with. So a lot of papers on the what. We'll talk a little bit about tonight about the preconditions that exist to make the system better in terms of managed competition, and the how. And I find the how really interesting, right? One paper that I've read talks about, well, who's the leaders in making the how happen? How do you be a leader in an environment to improve? And guess what? Unfortunately, the paper didn't find any, but it did find 3 characteristics that people who were a leader in a system that was changing, like the health system, exhibited. Those 3 characteristics were, firstly, they surface assumptions, beliefs, and what's happening. Secondly, they explore possibilities of how you can improve. And thirdly, they initiate collective action. So I thought that's interesting, the third one, because you're not just acting, you're initiating collective action. And in our system, it's states, it's federal, it's health insurers, it's hospitals, it's providers, it's the AMA, it's clinicians. So it's got to be collective to get some sort of action to happen. So a good place to start is, well, what's the objective? So I looked at the websites. I spoke to you, Brian, if you're there, but I looked at state websites, federal websites, and came up with, it's not really my own, these are written down, but universal access to high quality care. And this is the whole health system, not just the private health insurance. Universal access to high quality care that results in the best health outcomes at an affordable cost to individuals and the community. So we titled this talk, efficiency and affordability. So I couldn't help but go back to, what do we mean when we trot those terms off? Efficiency, I found pretty good definitions for, right? 3 things: technical efficiency, productive efficiency, and allocative efficiency. Technical being, we're using the resources we've got to the best advantage that we can. Productive being, we're not just using the resources to the best advantage, but we're getting good health benefits for that cost. So not all things that are technically efficient will be getting the best health outcomes. So productive is kind of a higher order. What I mean by those sort of crosses and ticks is you can't move from technical down to allocative. If something's got allocative efficiency, it would have technical efficiency. So let's move to the higher order one. Then allocative would be, it's got the right mixture of healthcare programs to maximize the health of the whole society. So that's what the literature says. Please speak up if someone knows them more than I do, but I think these terms get bandied around, and I even did it myself in the title of tonight's talk. But what do we mean when we talk about efficiency? You know, walk into some rooms, efficiency can mean cutting resources, cutting jobs, cutting heads, cutting people. So this is a technical literature definition in the academic papers. Technical, productive, allocative. So I want to talk a little bit about then, I thought I had a definition of affordability. I must have it later on. Talk a little bit about Australia's health system, because we have private health insurance, and I think we touched on it, Francesco, you did in your opening, that we want to separate financing or funding, or financing and funding, from delivery. And I find in a lot of talks and in a lot of papers, the two things get mixed together. So I'm going to say right at the outset, you know, we're talking delivery would be if I go to get a hernia operation, that operation is done and delivered and I get that. That's different to the funding and financing of it, which might be provided by the taxpayer, might be provided by the state, or it might be provided by a private health insurer. So it doesn't mean because you have private health delivery, you have to have private funding. So in Australia overall, there's roughly around 10% of the healthcare budget is private health insurance, and roughly healthcare is around about 10% of the economy. So the overall goal for private health insurance is written up the top, is to optimize the private contribution to funding the cost of healthcare provision. So having said the overall goal is to maximize private health insurance, it's deliberately to optimize private contribution to funding that cost. And try to keep in mind we're separating delivery and funding. I didn't update the sort of history of that, but it hasn't changed a real lot. You can see the main contributions to funding of healthcare, and the red line would say it's just a tick over 10% of GDP, and private health insurance is around about 10% of that. I want to talk a little bit about affordability, because I struggle with this term. It gets bandied around quite a lot. So I looked in the literature for it. Affordability is everyone has access to affordable health insurance, covering a basic package of services of acceptable quality within reasonable travel time. It's important in a big country like Australia, and without undue waiting time. So affordability includes accessibility. Actually, so that would be one definition. I struggle with this one because what would be affordable to a wealthy person, you might define as affordable, but someone who's sick and needs a lot of care might also feel that it's affordable to them to have health insurance because they're going to use it quite a lot and the alternative will be quite expensive. So there could be alternative definitions of affordability, and the term gets bandied around quite a lot. Just want to talk a little bit about the history of private health insurance. We've got, you know, around about 45–46% of people participating in health insurance now. You can see it's fluctuated from back in 1979, it was a tick over 60%. It went down. Then when the current, what's technically called sticks and carrots, rebates, Medibank levy surcharge, lifetime health cover came in at about the middle of that graph. It saw it head up, and then it's been fairly flat since then, and strangely in pandemic times it's actually ticked up just a little bit. Oh, I just did a little check. This happens to be a Bupa one, if we've got anyone Bupa on the line, but all funds are pretty similar. If I went to buy a silver, actually, I should explain this for the non-Australians in the audience, but private health insurance had got into a state of, we'll call it product proliferation. You know, it was probably quite confusing for consumers. We had all sorts of products. I've forgotten at last count, but you know, well into the hundreds of different types of products. And that was rationalized to create gold, silver, bronze, basic, and other. Now it has since morphed a little bit, where there's a silver plus and a bronze plus and things like that. But ignore that, and you can see that since January 2019 through to June 2020, we really did stabilize the gold, silver, bronze, basic. And you can see the split there is in Australia, gold being sort of the highest cover. Then there's silver, then bronze, and a little bit of basic, where there's basic has very limited cover. So I just want to go back to that, a silver plus policy. So silver almost gold by Bupa. Medibank is pretty similar. Other health insurers, they will fluctuate around that. For a single person getting no rebate and no lifetime health cover charges, it's nearly $3,000. By the time you add some extras and things, you'd be over the $3,000 mark. So that's what we're in Australian dollars, that's what we're talking about. I've been thinking about how would I evaluate what was working, or how would we evaluate what was working? Because it's not like there isn't a health system, there is one. So how do we assess what's happening? A lot of you and a lot of others have done that. I guess the guiding question would be, well, the question on my mind is, because there's a lot of papers and research on this, and we might talk a bit about it tonight, Francesco, but managed competition is the term that gets bandied around. I guess because unfettered competition is unacceptable in a market like health. So you need some form of managed competition. And the underlying assumption is that that is the best system for services. And then we use the criteria for that to evaluate Australia or against other systems. How should that program be organised? What resources are necessary and appropriate? I tried to group, well, we originally over on the right had, this is quite a cluttered slide, but we had something like 13 preconditions, and you might talk to 11, 12 and 13, Francesco, if you want to mention them. But I think the literature originally had 10, number 1 to 10 that I've put there, and I've grouped them and then tried to do a rating on them, but not a subjective rating, just for the sake of talking about this, right? But so if we just run through those and say the Australian system. So so A would be consumer choice and transparency, which happens to be preconditions 1 and 2. So to get a full score on that, you'd have to have free consumer choice. They can choose their insurer. You can do that in private health insurance in Australia, but the basic cover in the public system for all residents, so the universal cover for all residents, is provided through Medicare. There's not really any choice for that. They can't refuse customers either. If you turn up at a public hospital as a resident, you're covered, preconditions or not. And then in the private health insurance market, you can choose your insurer. There's no particular rating if you've got, or extra premium if you've got a pre-existing condition. Is there transparency of information? It's pretty good, but it's complicated. You know, it's for the private health insurance market, customers can go look at their price. Gold, silver, bronze has helped. Can they know the quality of the care they're going to get? I think it's In theory, yes, but it's challengeable of whether the ordinary consumer could really see through what they were getting. Is it accessible? Have they got a guaranteed basic package? Yes, in the public markets, you've got a guaranteed basic Medicare. Turn up at a public hospital, it might vary by metro or regional or public area just because of the services available. But in theory, the basic care is guaranteed. Okay, it's a standard benefit package, but once you move into private health insurance, it's not standard. We don't have a standard benefit package. I've already talked about, we've got at least gold, silver, bronze basic, and probably more because there's now silver plus and bronze plus. Market dynamics, are there risk-bearing buyers and sellers? Are there contestable markets? It's pretty interesting. Most of it's not entirely contestable because sometimes a provider or a customer or a service or a PHI has to have a contract with certain providers. In health, it's hard for it to be fully free and unfettered. Is there a regulator? Is there effective quality supervision? On quality, I'm probably not the best place to comment, but I think yes, overall, by government, state and federal, and by medical associations. It's a little bit less complicated in, it's a little bit more complicated in private health insurance. Is there an effective regulator? There's an ombudsman, there's an APRA as a prudential regulator. We're probably a bit diffused. No conflict of interest by the regulator. Well, on the financial side, APRA is the prudential regulator. I think they would say they have a conflict of interest if they were to change any of the settings in health that might affect the solvency or the capital of a health insurer that they are then regulating the solvency or capital of. Cross subsidies, I put there the ratings I've put as somewhat subjective on the 1 to 5, 1 being lousy, 5 being great. You can see that I've plotted the Australian system in the middle there. I think the plots are somewhat arbitrary at the moment until I work through that. Number 5 and 6 in the preconditions were freedom to contract and integrate and effective competition regulation. There's no real competition for Medicare and the public system. There is a competitive market, although managed for voluntary private health insurance. And finally, I haven't got a graph of this, but affordable out-of-pocket payments. Out-of-pocket payments have been going up. It's probably the fastest growing segment of the health insurance market in Australia. So that's the what, and then I think the next step would be if I could agree the plot of where we're at on those preconditions, which are not mine, they're a depth of research behind them. You then look at, well, presumably you'd want the alternative system to be a little bit to the right. You can't be 5 out of 5 on everything, although you might want to be. Probably take significant investment of time, resources, and effort to get to that. So the question then becomes, what do you move? Which parts of that? If they're the current ratings, would we want to move the competition further? Do we want to move regulator further to the right? Probably, and in which order? Which ones would you move? Which ones would you move in the short term? Which ones would you move in the long term? And our underlying assumption here is that meeting those preconditions for managed competition is a neat is a good direction for Australia to take. I'm going to stop there, Francesco, and just see if we've got any questions rather than me rattle on.
Okay, excellent. Let me open to everyone. Obviously, there was a comment. Sorry if I pronounce it wrongly. Luis Vinyals. Thanks for joining us. The comment was affordability should be related to the ability to receive care at the point of use or when in need, and not particularly to premiums. Yeah, I suppose that was reflecting to your comment that it's hard
Yeah.
to understand sometimes what the terms affordability
Well, I
means.
meant when I meant it's hard to understand. You know, if you go to any forum on health insurance or anything else, you'll often hear even executives stand up and say the number one issue in our industry is affordability. And yet, when you go and look at the research, or even if you ask that person, could you define affordability for me? It's not well defined. It means different things in different countries, and often it means different things to different people.
Yeah, you're right. It's interesting. Probably it depends also, and Louis makes a good point. Affordability of what, right? So, in his case, probably is thinking. I'm not sure. And Louis, please, follow up if I'm misinterpreting. But I guess your comment says fundamentally that in health, like in other areas, there is a risk underlying to be defined at the individual level, and there should be an ability to some extent to be able to price that risk. And obviously globally you would think of once that price is determined, which includes also the care at the point of delivery, because that price includes the cost of the actual care delivered, if and when it's needed, then affordability would actually mean whether it is possible for people when they're sick, but also when they're not, to be able to contribute. And obviously in some systems, and we have Professor Van Ven here from the Netherlands, in some systems, the level of affordable access to coverage is sometimes very generous, meaning that I think in the Netherlands it's still about 2/3 of the population that receives some support, financial support for the government to actually at least be able to pay. In some cases, the individual contribution is very close to zero for the most vulnerable groups in society. So thanks for the comment, Luis. I think that was a very.
I think there's one other comment I'd make on Lewis's one, right? Is we can define affordability, Francesco, as go back to that original definition. It was affordable to an individual and to the community. So, and I'd go with Lewis, your definition is affordable. Affordability should relate to getting care when you need it. I think that would be correct. That would be care is accessible, but is it affordable to the community to provide that level of care? That would be it's affordable to you as an individual, but is it affordable to the community to provide that?
Yeah. Okay, so far that's it, Andrew. You want to continue, or you have more slides, or?
Yeah, I do have a couple more, but I thought, how are we going?
Here we have Marva. So we have 30. So in the light of the pandemic, are there signs of undertreatment? Can we categorize this inefficiency? So obviously in Australia, Andrew.
This is very difficult, right? I think there has been signs of undertreatment. If you looked at breast cancer screening, for example, through the Cancer Council, cancer screening is down. The number of mammograms done is less than before. In private health insurance, the number of claims private health insurers is down significantly, resulting in many insurers paying something back to customers. What we're not sure on is the effect of that. Will those claims A, disappear, B, come back at a later stage, or come back at a later stage with even worse conditions than if they had been treated regularly? So the question, are claims and screenings down? Absolutely, there's evidence of that.
Okay. All right, so we have pretty much 25 minutes to the end, so you might want to continue, Andrew.
Yeah, cool. Okay. So the next thing I was looking at was, well, how do we assess efficiency? How do we assess Are we getting a cost-effective program in health for what we're putting up? Are there sufficient benefits in comparison to the cost? So this comes back to Lewis's question, you know, can an individual get access to care? Yes, but is community, we can arrange for that to happen, but is the community paying an acceptable cost for the care that it's getting, or could it pay something more efficient by an alternative method of getting that same care? And what would that alternative be? And could it perform better? And then an interesting question is, let's assume you could find that, how would you move to it? I think we can find it in a number of areas. So look, let's look at private health insurance. What's the goal overall? I'm trying to, as an alternative or supplement and a replacement for the public system, it needs to be more efficient. So are there incentives for efficiency either here or around the world that we can improve on? We want to mitigate risk selection, so we don't want someone who's sick or unwell or high cost to not be able to access the system. And we don't want insurers to avoid those type of people because they cannot get enough premium to justify the cost of insuring such a person. On the flip side, we want to keep premiums affordable for high risks. So we want people who are unwell and high cost to be able to get care. And we don't want to create a system that has incentives for gaming. So we don't want a system that encourages insurers or actors in the market to do actions that are not optimal. I'm going to quickly touch on this mysterious thing called risk equalisation. We have it in Australia, we have it in many countries. So why do we even have it? Because we don't want risk selection. We don't want insurers to look for healthy people because they'll get a premium that exceeds the cost of the claims. So whether they look for them because they're allowed to, or even if they're not allowed to, by the way they advertise or the way they structure their products. Why don't we want risk selection? Because it undermines community rating. And in Australia, we have a thing called community rating. If you interview people, you'll get a very positive story about it. On the same time, people are often trying to bend it or move around it. So we're trying to avoid that by mitigating it, because we want to support community rating. And you can sort of go a bit further and we'll go, why have community rating? Because you want to keep premiums affordable for high risks. So in the literature, it would be solidarity. So why risk equalised? You want to mitigate risk selection. Why mitigate risk selection? Because we want community rating. Why do we want community rating? Because it means there's a fair and just and equal premium for all, high or low risk. But it does mean you've got some sort of cross subsidy in the system somewhere. I'm going to touch on one that Richard did for me from the Netherlands, but just see if I got that. Yeah, look, we're talking about community rating. What do we mean by that? It's the green line, right? It's the same premium, no matter what health you are. Notice across the bottom line there, if you're in good health, you pay the green line as premium. If you're in bad health, you still pay the green line as premium. Your real cost might be the black line, the curvy one, right? So for people who are in good health, we will make a predictable profit, right? Because we will collect a premium and they will pay a premium that actually exceeds their underlying cost. On the right-hand side, we'll make a predictable loss because insurers will make a predictable loss because they cannot charge a premium equal to the cost because of community rating. So they will collect a premium that is less than the cost they will pay out. So you can see that community rating introduces a challenge that we're going to have predictable profits and we're going to have predictable losses. So if we're running an insurance company, this creates two problems, right? Or two challenges. I often call them challenge 1 and challenge 2. So challenge number 1 is participating. Like, why, if I'm in a group and my group is of good health, why participate? Like, I'm going, as a group, we're going to pay more than the benefits we're going to get back. So the policy options are down the bottom. In Australia, things like lifetime health cover, LHC. Not in Australia, but in other countries, there's a mandate to say, well, you might choose not to participate, but you have to. In Australia, we have a penalty, an MLS, a Medibank levy surcharge. Equally, you could have subsidies or rebates, as in you contribute to the premium for people to say, yeah, here's a bit of a top up to help you afford buying health insurance. Challenge number 2 is more at the insurer end, right? Insurers on the right-hand side of that graph, insurers in theory would be better off not to insure people where they're going to get a predictable loss. So how can we improve that? We can improve that by having some sort of risk equalization, commonly called risk adjustment or risk sharing. Right, 2 typical tools which we just went through, in that challenge number 2 on the right were risk adjustment and risk sharing. I've got a definition for those in the paper, but risk sharing is really sharing actual costs that have occurred. Pretty simple to implement. It's pretty easy to share an actual cost. There's no real argument about what the dollars are. But by sharing the risk, I don't have much incentive to control that cost. Risk adjustment, on the other hand, is using some sort of predictor or indicator of expected health costs. It's a little bit more complicated. It takes a little bit more design and implementation time, but it gives much more incentive to control the cost, because if an insurer and a provider or an actor in the system does not deliver the service or arrange for it at that cost, it can be higher, in which case they're a loser, or lower, they're a winner. So they have an incentive to keep the cost down, because they in effect will suffer a penalty if they do not. So that's what I meant by risk sharing and risk adjustment. I won't go through that, but different countries do different things. It's fair to say in Australia, we're recently doing a piece of work that we're discussing with a lot of the private health insurers. There's there's dissatisfaction with the current system, thinking that we could do better. That's the first call. If you're happy with the current system, you wouldn't change. Is there a better system around the operating? The answer is yes. There are better systems around the world. If we test them against our system, they test better. So a better system would be this one I've put in yellow here, is that we replace what is in Australia. Only got 2 factors really, is based on the actual cost. We reimburse insurers based on the age pool, so they share the costs a little bit more as people get older, beyond 55. And if it's particularly high cost, that gets shared. If we replace that with a hybrid system that allowed a bit of upfront risk adjustment, say like the Netherlands, together with the risk sharing type approach we have in Australia, we think it would perform, I think it would perform better than the current system. It's not entirely a surprise, because if I play 10,000 simulations and limit one set of simulations, or 2 people playing a game, I guess, and one person can only use cost sharing, and the other person in the simulated games can use cost sharing, targeted cost sharing, and risk adjustment, they will likely win more times than they will lose as they put those things in place. Now, it's not easy to do straight off. So how can you move to that? You want to continue to improve, continue to add things. And I did have a slide in here, Francesco, that let's just see. So this one's from the Netherlands, right? You can see I won't go into the detail of what's in this slide, but their system started in 1991 or even around about then. It took a long time to get towards today, where it's much more based on financial responsibility of insurers or towards the risk adjustment system. So assuming you can wave a magic wand and start right here, right now, is very difficult. So there's an example of a what, right? We might want to move from the current system, or at least it would actuarially analytically test that we should, to a hybrid system. If we ran simulations, that looks a superior system. I want to do it progressively. So I've answered my 3 questions, if you like. I say, am I dissatisfied with the current system? Yes. Is there a better system? Yes. Can I move to it? Well, that's an interesting challenge, right? But if you looked at somewhere like the Netherlands, you would say, yes, we can. So, or another example would be, you'll move to it over McKinsey's type model of time horizons, where you might move a little bit in Horizon 1, a bit more in Horizon 2, and even further in Horizon 3. In fact, that's kind of what the Netherlands did. So I might stop there, Francesco, and say, it's kind of interesting to think about, should we move? What should happen? I think there's a lot of research on that in Australia. There's a lot of people saying you should do this or you ought to do that. Probably fair to say that everyone in our complex system, whether it's state, federal, the AMA or private health insurers or smart people, say, yes, you should change. We look around the world, there are possibilities that we could draw into Australia. The question now is how? How do you move from what you should do to how you should do it? So I found quite a lot of research on the preconditions, the managed competition, the what you could do to make the system better. The challenge now is to think through how. There are so many players in a complex system. It's not an easy thing to move. And, for example, we've just changed one of the players, right? We've moved from one federal government to another because we've had an election in Australia. So I'm going to stop there, 6:47. Back to you.
Thank you, Andrew. That was great. And indeed, that's probably one of the questions that comes to mind as soon as you enter a project like this. Really, that tries to really think about how things can be improved. It's definitely the first thought is how that implementation phase, if you like, materializes. So while we think about that question, which is often the ultimate challenge in policy making, yes, I suppose I would like to invite everyone to share comments in the chat or Q&A. Let me just monitor whether something appeared in the Q&A. In the meantime, we have Tom Shore. Thank you, Tom, for joining us today. Tom says, thanks for speaking, Andrew. Really interesting topic. I would be interested to hear your thoughts regarding the funding from and profits returning to overseas investment and private equity funds. I'm thinking specifically at the moment about the potential sale of Ramsay Healthcare overseas. Should Australians care who owns the country's hospitals and where profits go? And do you think multinational corporate ownership has or will have any impact on the accountability and transparency in the provision of healthcare? Well, definitely, this is a very interesting question. Yes, I can break it down if you want me to, or you should be able to read the chat, but I'm happy to.
Yeah. Did you want to comment on that, or you want me to do that?
No, I'm happy for you to go for it.
Okay. Well, I think this is interesting because we've got an overseas fund looking at buying into Australian healthcare at the moment. So look, I'm not sure that I'm the expert to comment on that, but if you went back to those preconditions, we're saying if that was achieved in Australia and the overall objective was being achieved, good quality outcomes, health outcomes at an affordable cost to the community and the individual, at first blush, we're pretty happy. I don't think we should accept a substandard cost or substandard outcomes for Australians by saying, no, it can't be provided by someone overseas. So we can continue to hold both the overall objective and the preconditions, I think, in place. And we're saying, well, will that be met, or will that be made smaller or marginalised because an overseas parent owns the hospital? I think that remains to be seen. It could actually be better. I don't like the idea of Australia and hospitals going offshore, but I think we've got to come back to the overall goal and the overall preconditions. So the answer, I think, Tom, must be it's yet to play out, but we've got to hold it. It's managed competition, not unfettered. And we've got to keep those outcomes and keep those preconditions happening. That help, Tom? I'm not sure if I've fully answered your question.
Yeah, no, I think it does answer the first part.
I think the second part.
I think that the second part, it's probably related. I mean, you could see it also in the global context where actually the sort of rules of investments may change. There are fiscal implications, obviously, rules that apply differently in different countries. And I suppose the second question is about how the connection is between ownership, and basically maintaining that objective. So it's more directly related. Can we really have assurances I think everybody would have a different opinion. I think it makes.
Then we got to be careful, though, Francesco. You come back to the overall goal and the preconditions, right? One of them is that we've got contestable markets. So if we've not got contestable markets because it's all owned by one overseas fund, then that's a failure in that precondition.
Yes.
So I think I would say then it is definitely substandard, and we should do something to control that. On the other side, if you continue to allow competition should mean that it is not effective to be that sort of ownership. Now that's not easy.
So fundamentally, in a nutshell, summarizing your response to the second point, you're saying that, of course, ownership matters, but it's certainly transparency, and that is important. But whether it's national or overseas is less relevant in case there is, or provided there is a regulated competitive environment.
Yeah. Now, if I was the overseas fund, I would be trying to make sure I could stamp out competition or be a monopoly or
absolutely
or operate without that sort of. So we've got to somehow keep that going. If there's contestable markets and there's competition and there's choice, it's going to be harder for the overall goal to not be achieved because it's owned by overseas. But flip side, Australian 100% owned companies in a contestable market are not able to provide a better outcome at a better cost, then that's pretty sad. But it's not unreasonable to have that sort of challenge.
Absolutely. No, I think that's a very good point. Questions, and also there is quite a bit of history of let's say international global organizations, also in the health insurance with Bupa entering not only, of course, Australia, but also many other countries, Chile, and it's very global insurance firm. And certainly that comes also with the know-how and the job, of course, of the regulators to ensure that there is a level playing field in accountability and transparency. Now, moving on to the other point that is raised by Caroline Watts. Thank you, Caroline, for joining us and for your question. Can you comment on, please, Andrew, the out-of-pocket costs and the drivers of this, and will increasing out-of-pocket costs discourage entry into PHI.
I mean, I think it's not just, I mean, you've probably got some comments on this as well, Francesco, but we did a joint paper a little while ago and be a little bit out of date, the stats now, but we found that out of pockets were one of the highest and fastest growing things in the health sector. Now, I should say, Carolyn, not just in private health insurance, but right across the market. So, for example, if an individual goes to a GP clinic on the weekend, they often have to pay $90 or $100. That's a lot of money. Bulk billing is not everywhere, so that means that person's got an out-of-pocket. Sure, they can put in a Medicare claim, but they won't get 100% of it back. We've seen health insurers move to bigger excesses. $250, $500. Recently, more common is $750. So to buy an excess or a copay is, you pay the first $500 or $750 when you go into hospital. What's the driver of that? I guess it's partly market. My health insurance, I just got the bill, is for a Silver Plus family policy is just over $8,000. They could market it to me a little bit better if I'm, or at a lower price if I'm prepared to take a higher cost. Of course, when I go to hospital, I pay a bit more. So I think there's a multitude of reasons. The sad one is it's probably the way the market is working to people least able to defend themselves. When we want to play a risk game and we pass the risk around and pass the cost around, you pass it to the person who can't pass it off. So out-of-pockets are an easy place for it to go, and we're seeing that at the moment. It's being pushed up. Francesco, you might have some comments on that.
No, I think this is very good question, Caroline. Very good call, Andrew. I invite everybody to share their experiences overseas. I would have to say that when you think about insurance, really, you think about different ways in which out-of-pocket payments may even be beneficial. When you think about out-of-pocket payments in isolation, and you think of them increasing, or you observe them increasing, I would say that it's a little bit different, the proposition or the problem. I would say that the rise of out-of-pocket costs in and itself, if detached from insurance products, and we call them excess here, I think that is of a concern, because it really creates, if you think of what individuals pay to access, for example, healthcare services, so there is no insurance really there. If those go up, for example, to access GP care, that's a concern, that because it really creates an equity problem, right? Who can pay may go to a GP, or otherwise the system entry point becomes emergency, which is not necessarily efficient. Now, so in and in itself, I think looking at out-of-pocket needs to be done in pondering what we really mean by out-of-pocket payments. Because if built into insurance products, it might be a good mechanism to deter moral hazard, right? So we have to be careful also on the level of out-of-pocket payments and so on. Certainly, increasing out-of-pocket costs in and itself is concerning, because it raises equity issues, and there are better ways to organize this. And insurance, even voluntary insurance, is a way to do that. And look, I mean, putting out an idea to conclude, perhaps, and then giving back to Andrew to the final remarks. One of the questions when I came the first time in Australia that really surprised me of this model is that we couldn't, for many reasons, really allow GP care costs that are not covered by Medicare to be, covered by private insurance at all, right? So that is clearly a superior pooling mechanism that pulls together heterogeneous risks to the point that creates almost naturally more equality in the actual, price paid than out-of-pocket payment. So I concluded that my comment on that beautiful comment, Caroline, and all the rest, Tom, Marva, and also Joe Portelli. Thank you. He actually commented, I suppose, to Tom Shore comment by saying that HealthScope, has done that. Market penetration a few years back. So thank you, Joe, as well. Thank you, Andrew. Closing remarks, Andrew?
I think you just see, I think even Caroline's question on the out-of-pocket shows how hard the how is. If we in a complex system, if we only change, keeping health insurers to have low premium increases or controlling doctors' costs, it might cause a spiral out of pocket. So, you can control one area and it breaks out somewhere else. Like when it's almost like stepping on a floor with balloons in it. The bubble comes up somewhere else. So, it's a complex system. So there's a lot of parts to manage. So this how piece becomes very, very challenging. Everyone knows what to do.
Thank you, Andrew. And on that note, I really appreciated your time with us. And to the participants, please send us your feedback, comments on this talk, and follow us. We'll be back following up on this topic in about a month time with a very interesting, I'm not gonna announce too much because we have to secure some of these panelists, but a conference that really goes into the details of how, in fact, the public-private mix may consider options for a positive change. So not only in Australia, we will take an international approach in the next webinar in July. So thanks. Of course, we put this recording available on our newsletter and website of the Value Health Economics and Policy group if you're interested in joining and receiving more updates from the work we do in this and other spaces. Of course, look at our web and write to me, and we'll definitely include you in our membership. There is no fee to pay at all. It's a community of people with a passion for health policy and that want to discuss the challenges that we're facing. So thanks for all those who joined from Europe and the rest of the world. I imagine India, but I forgive you not to be able to understand exactly from the name where you are connecting. So thanks, and enjoy your day or evening, and see you next time. Bye.
Thank you.